Position the patient on a stretcher with the head of the bed elevated. During all maneuvers, including examination, irrigation, and manual extraction, it is beneficial to retract the pinna posteriorly and laterally to straighten out the external auditory canal. During visualization, you can use your non-dominant hand to both retract the pinna and to hold the otoscope, which leaves your dominant hand free to manipulate instruments. Several drops of a cerumenolytic agent may be administered as pre-treatment 15 minutes prior to irrigation or extraction if desired. Use body temperature tap water or normal saline for irrigation of the external auditory canal. Failure to use warmed irrigant may cause a cold caloric response and significant patient discomfort, including nausea, vomiting, and vertigo. A butterfly intravenous assembly is ideal for irrigation of the ear. Cut the needle off the tubing, and then attach the catheter to a large syringe. Place a towel or absorbent pad on the patient's shoulder and an emesis basin under the ear to collect the effluent. The patient may assist in holding the basin if he is able. Fill the syringe with the warmed fluid. Retract the pinna and begin to irrigate. Try to aim the catheter superiorly and slightly posteriorly to decrease the chance of the stream directly striking the tympanic membrane. Usually 30 to 60 milliliters of fluid is used. After irrigation, position the patient's head with the affected ear down for a minute or two to allow the irrigant and/or waxy debris to drain out. Re-examine the canal and consider using one of the manual extraction methods discussed later in this video to remove any superficially lodged debris. There is no consensus on what constitutes treatment failure with regard to irrigation, but it is reasonable to make several attempts. Stop if there is suspected trauma, sudden pain, hearing loss, or cold caloric symptoms. Examine the impacted cerumen with an otoscope prior to attempting manual extraction. Removal of the cerumen must occur under direct visualization to prevent iatrogenic injury. You must slide the otoscope's magnification lens off to the side to allow passage of the instruments through the scope. The hand holding the otoscope should rest against the patient's head during the remainder of the procedure. This allows your hand to move as a unit with the patient's head and will prevent injury should the patient suddenly move. Commonly available instruments suitable for manual extraction include the ear curette or ear scoop, the alligator forceps, and the Fraser suction catheter. To use the ear curette, carefully insert it into the canal under direct visualization. First, gently separate the cerumen from the wall of the auditory canal, and then drag and pull out the waxy debris. Try to pass the curette around the cerumen, and then, once behind it, gently withdraw to dislodge the impaction. Like the ear curette, the alligator forceps must be inserted through the otoscope head and into the ear under direct visualization. Grasp dislodged pieces of cerumen and remove them from the canal. It is often beneficial to perform irrigation and loosen the impaction with a curette prior to using the forceps. A Fraser suction catheter may also be used to remove loose pieces of debris. To apply suction, occlude the port on the handle with either your thumb or finger. As with other manual extraction methods, insert the suction catheter into the canal under direct visualization. Advance the catheter until the tip is in contact with the cerumen, cover the port on the handle, and then gently withdraw. Manual extraction is often quicker than irrigation. However, it may be more uncomfortable to the patient and can cause injury to the delicate external auditory canal. In most cases, especially if the cerumen is deeply impacted, it is prudent to attempt irrigation before manual extraction.